Today, I'll be discussing abnormalities of the diaphragm and pleura. The learning objectives are to be able to identify these abnormalities, including air under the diaphragm, and to be able to list the common etiologies of each. I'll start with the condition of pneumothorax. A pneumothorax is when air is within the pleural space surrounding the lung. I first introduced this condition in Lesson 4 on airways and bones, where I described a massive pneumothorax as a cause of airway deviation, and in this case here, total lung collapse. Luckily, most pneumothoraces are not that large, though of course this makes the diagnosis harder to spot. Consider this X-ray. Do you see anything unusual? If you look closely at the lateral aspect of the right lung, you'll notice a subtle vertical line, lateral to which there are no lung markings. A pneumothorax. The size of a pneumothorax is given in very qualitative terms and is based on the thickness of the rim of air around the lung at the level of the hilum on a PA film. Less than 2 centimeters is generally referred to as a small pneumothorax. Greater than 2 is referred to as large. Because some smaller pneumothoraces are easy to overlook, there are a few tricks that one can use to make their presence easier to identify. One trick is to compare inspiratory to expiratory films. Obviously, the standard film is an inspiratory one. How would an expiratory film change the appearance of the pneumothorax in this patient? As the patient exhales, the lung volume becomes smaller, while the volume of the intrapleural air remains the same. Since the diaphragm is higher during expiration, a constant intrapleural volume means that the pneumothorax will be wider. Also, on expiration, the lung parenchyma becomes more crowded and thus wider on an X-ray, increasing the contrast between the lung and pleural air. And here's the expiratory film. The pneumothorax is much easier to see. And in fact, if we look closely, we can actually see another pneumothorax on the opposite side, which was not clearly evident on inspiration. Another trick that is sometimes used is to look at the inverse image of the chest X-ray. Compare the right-sided pneumothorax on the conventional view with that on the inverse view. I personally don't find this helpful, but many people do. Lastly, there is a specific appearance of a pneumothorax that is occasionally seen in AP films of semi-recumbent patients. What do you notice here? The right costophrenic sulcus seems quite pronounced. This is called the deep sulcus sign and is an indication of a pneumothorax. The etiologies of a pneumothorax are numerous. Clinically, they are divided into 2 categories. A primary pneumothorax, often referred to as a spontaneous pneumothorax, is one which develops in the absence of any lung disease or potential iatrogenic procedures. A secondary pneumothorax can be caused by procedures such as thoracentesis, lung biopsy, or a central venous catheter placement. It's also seen in COPD, cystic fibrosis, and rarely as a consequence of pneumonia. Next up are pleural effusions, which are collections of fluid in the pleural space. Here's a particularly dramatic one. The characteristics of an effusion that you should be able to describe based on an X-ray include whether it is unilateral or bilateral, a qualitative impression of its size, whether it is free-flowing or loculated, and any associated findings that may suggest the etiology of the effusion, such as cardiomegaly and pulmonary edema, suggesting CHF. An interesting phenomenon occurs when effusions develop that is a consequence of the curved geometry of the diaphragm. Imagine a side view of a patient with a lung here and a relatively small effusion in the gravity-dependent posterior costophrenic sulcus. If I put an X-ray film behind him and shoot some X-rays, how will this effusion appear on PA and lateral films? On a PA film, since the top of the effusion is still below the superiormost aspect of the diaphragm, it will not be visible. However, on the lateral film, you'll be able to see it as a blunting of the posterior costophrenic angle. The general rule is that small effusions will be visible first on the lateral film before they become visible on the PA film. In fact, it can take several hundred cc's or milliliters of pleural fluid to accumulate before it can be seen on the PA. So here are two examples of left pleural effusions. The effusion in the X-ray on the left of the screen is noticeable only from its blunting of the costophrenic angle. Because of capillary action of the fluid, the effusion often tracks slightly upwards along the pleural surface. As mentioned, an important characteristic of pleural effusions is whether they are free-flowing or loculated. Loculated effusions are ones in which the fluid is subdivided into separate compartments that do not freely communicate with one another. They are caused by pleural adhesions from long-standing inflammation or a hemothorax, which is blood in the pleural space. Recognizing that a pleural effusion is loculated is important because loculated effusions do not drain easily. When effusions are free-flowing, they make a nice meniscus that adheres to the principle of gravity. When effusions are loculated, they are in an unusual location which seem to defy gravity. Occasionally, when a loculation is this dramatic, it may be difficult to distinguish this from a pleural-based mass without the help of a CT scan. In addition to the PA view, often clinicians will request a lateral decubitus view to assess how free-flowing an effusion is. In this view, the patient lies on his or her side with the effusion side down. If the effusion is free-flowing, it will shift due to gravity. If loculated, it will either not shift at all or shift only partially, as seen here. There are two subtypes of a pleural effusion that can easily be mistaken for something else. The first subtype is something called a subpulmonic effusion. In this, fluid accumulation occurs between the lung base and the diaphragm and does not track up the pleura. Therefore, it does not blunt the costophrenic angle. This is primarily suggested by the pseudodiaphragm appearing to peak more laterally than normal and appearing more horizontal than normal. On the left side, there may be an abnormally large distance between the gastric bubble and lung base, while on the right side, there may be an abnormally high horizontal fissure. Here's an example of a right subpulmonic effusion. Notice how the diaphragm is more horizontal than normal and appears to have a very lateral peak. Also, the horizontal fissure is very high up in the thorax, implying that the lung is being compressed from below. And here's a left subpulmonic effusion. Notice the significant distance between the gastric bubble and the pseudodiaphragm. The second, easy to misdiagnose subtype of effusion is sometimes referred to as a pseudotumor. This term is most commonly used to refer to a fluid collection trapped within the fissure, which can give the appearance of a lung mass. The suspicion that a density represents trapped fluid is based on its location at a fissure, most commonly in the horizontal fissure as shown here. Also, these collections often have a smooth lenticular contour. There are many etiologies of pleural effusions. I will not list them all here, since the vast majority of these cannot be distinguished from one another based on X-ray appearance. However, I'll mention just the most common. As you may know, pleural effusions are almost always subdivided into so-called transudative effusions, which are those secondary to an imbalance between hydrostatic and oncotic pressures within the pleural space, and exudative effusions, which are those secondary to pleural inflammation or lymphatic obstruction. Transudative effusions can be caused by heart failure, a hepatic hydrothorax, which is a pleural effusion due to leakage of ascites through the diaphragm, hypoalbuminemia, and nephrotic syndrome. Exudative effusions can be caused by pneumonia or a primary infection of the pleural space called an empyema, malignancy, pleural tuberculosis, pancreatitis, sarcoidosis, and various rheumatologic diseases. There's one final thing to mention about pleural effusions, and that is how an insufficiently upright position can affect the assessment of the effusion size. Here is a side view of a patient who is completely upright, and we'll give her a moderate size effusion. Since the top plane of the effusion is parallel to the X-ray beams and perpendicular to the film, the resulting sharp meniscus on the PA film will allow for easy comparison between serial exams. However, what if the patient is not completely upright, but is rather lying in bed semi-recumbent? In this case, even if the X-rays appropriately strike the patient dead on, the level of the effusion no longer is perpendicular with the film. As a consequence, the meniscus will be blurred. This will make serial comparisons very difficult. Also, when this effect is particularly extreme, it can even make identification of a small effusion much more difficult. Let me move on to some miscellaneous forms of pleural disease. This includes pleural plaques, pleural thickening, and pleural-based malignancies. These visually fascinating opacities are all examples of pleural plaques. They are typically bilateral, multifocal, and relatively symmetric. Each individual plaque can appear scalloped or shaped like a holly leaf when seen front-on, while those seen edge-on appear more linear. The apices and costophrenic angles are relatively spared. Pleural plaques have the shortest differential diagnosis of any chest X-ray finding, as they are always indicative of prior asbestos exposure. It's important to realize that while pleural plaques and asbestosis can coexist, they are not synonymous. Asbestosis is a parenchymal lung disease caused by asbestos exposure, but it is not a disease of the pleura. Here are two examples of diffuse pleural thickening, which is from a combination of pleural fibrosis and fat deposition. Use of the word diffuse is a little bit of a misnomer, since it does not typically involve all of the pleura on the affected side, though often obliterates the costophrenic angle. Regarding the differential diagnosis, it is usually a long-term consequence of intense inflammation. This can be seen in various prior infections, a prior hemothorax, occupational exposure, radiation, and of course, malignancy. The final pleural abnormality is a pleural-based malignancy. These can be difficult to conclusively distinguish from soft tissue masses or an unusual loculated effusion. Most pleural malignancies are the consequence of metastatic disease, either hematogenous dissemination or direct invasion. However, mesothelioma, a primary malignancy of the pleura, has a very increased incidence in patients with prior asbestos exposure. Let me move away from the pleura and talk about the diaphragm for a minute, specifically the finding of an elevated hemidiaphragm. There are a number of reasons this can occur. It can be from diminished lung volume, phrenic nerve paralysis, eventration, which is an abnormal contour of the diaphragmatic dome due to incomplete muscularization, also a subphrenic abscess, or hepatomegaly or splenomegaly. Finally, I'm going to go through all of the remaining pathologic places that air can accumulate. First up is pneumoperitoneum, often referred to as free air under the diaphragm. This can be from a perforated viscus, a consequence of recent abdominal surgery, trauma, or is a normal consequence of peritoneal dialysis. What do you notice in these X-rays? In each, there appears to be a pocket of gas in the mediastinum within the cardiac silhouette. This is how a hiatal hernia looks on X-ray, which occurs when a portion of the stomach herniates upwards through the diaphragm into the thorax. While patients can develop significant GERD-like symptoms from this, it also can be surprisingly asymptomatic. Where's the abnormal gas in this patient? There are two locations. The easier one to spot is the subcutaneous emphysema in the neck. But look closely at the left mediastinal border. See this extra line right here? The intervening dark stripe is air in the mediastinum, a condition called pneumomediastinum, which often coexists with subcu emphysema. Causes of pneumomediastinum include trauma, esophageal rupture, vomiting, asthma, neck or chest surgery, and barotrauma. This is easy to mistake for pneumomediastinum, but in this case the air is actually inside the pericardial sac, a condition predictably called pneumopericardium. This is distinguishable from pneumomediastinum because the band of air is always single and more well demarcated than in the other condition. While pneumopericardium can outline the base of the aorta and pulmonary artery on occasion, it cannot extend further superior to the aortic arch or neck. Etiologies include trauma, bacterial pericarditis secondary to a gas-producing organism, a consequence of cardiac surgery or pericardial drain, or very rarely a fistula between the pericardium and either the lung, stomach, or esophagus. And here is the very last finding of the day. What do you see? Most people initially see what appears to be free air under the right diaphragm. However, what is responsible for this linear shadow? This finding is called Chilaiditi sign, which is due to part of the colon becoming interposed between the dome of the liver and the diaphragm. It can be distinguished from free air by the presence of rugal folds, which was responsible for that small line. Obviously, it's easily mistaken for pneumoperitoneum. Like a hiatal hernia, this can also be amazingly asymptomatic. However, the term Chilaiditi syndrome refers to the condition in which abdominal pain or other symptoms, such as those from obstruction, are related to the unusual location of the colon. That concludes the abnormalities of the diaphragm and pleura. The next video in this series will discuss diffuse abnormalities of the lung parenchyma.